Hi, good evening all. We welcome you to the ninth PEP teaching program. This will be on initially by Prader-Willi syndrome and later by growth hormone deficiency. We have two eminent speakers in their specialty. Dr. Kavita Bhatt Madam from Bengaluru. She has the Prader-Willi Syndrome Society and very exhaustive uh, research work is going on their institute. We welcome Madam. And also second by Dr. Vijay Kumar sir, professor from Calicut Medical College. Now I request our president, Dr. Ahila Ayavu Madam, who is very dynamic and very much into academic research and also in recent advances. So I request you to start the program. Thank you. Ahila Madam. I think she has some network issues. She lost the line. Kavita Madam, just you can say some introductory talk and can start. Unmute Madam, Kavita Madam, unmute yourself. Yeah.
All of you to this teaching program aimed at pediatric residents. Dr. Amarnath has been doing a great job month on month, putting all of us together. And I hope you all enjoyed. I welcome all of you to this meeting. Thanks.
Thank you, Madam. There are few instructions. Please note, please be interactive and ask your doubts in question answer box and chat box. Apart from the presenter, various discussants are there in the panelist forum. Please do participate actively, just like a case discussion, a case presentation, external exam. And Dr. Vijay Kumar sir is also there. He can also ask any questions regarding to your Prader-Willi syndrome case. So, let us start the case. We wish you all the best. So, for this case, Prader-Willi syndrome, Dr. Seema Rai from Marine Corps, she is associate professor. We thank you, madam, for accepting this case presentation.
Thank you, sir, for the wonderful opportunity.
This chance. Over to you, Sumit. All the best.
Okay. Thank you so much, sir.
Just 1 second. Ahila madam has joined. Madam, 1 or 2 words, please.
Good evening, everyone. It's a pleasure to be here today and put in fantastic work. I think has not
Thank you very much, madam. We will be telling you one surprise gift for all of you from madam side, Ahila madam. This Ispae conference in November. So all postgraduates have a quiz. We are going to tell the details.
Anyway, thank you, Amarnath.
Thank you, madam. Thank you very much. Thank
my
you.
connection on.
Thank you. Yeah.
Bye. Thanks.
Yeah. Please go ahead, Sumit.
Should I? Okay. Okay. Thank you so much, sir.
Go to slideshow, please. Yeah.
Good evening, everyone. Hello. Am I audible?
Yes.
Okay. Good evening, good evening, everyone. Good evening, everyone. I'm Dr. Sumit Chablani, junior resident in pediatrics in GGSMCH Faridpur. I'm going to present a case on Prader-Willi syndrome. and it's being guided by Dr. Seema Rai, who is my guide, who is associate professor in pediatrics, and
Okay,
is
start.
also my guide. So we'll present with a 3-year-old female resident of Faridkot came to OPD at GGSMCH. Informant being the parents and reliable. They came with the complaints of weight gain for 1 year and difficulty in walking for 6 months. In history of presenting illness, parents noticed the increase in weight and tightening of clothes and increase in waist circumference from 26 inches to 35 inches. We have also taken in centimeter, from 65 centimeter to 87.5 centimeter. And there's an increase in a weight gain from 17 kg to 32 kg in a span of 1 year. Parents also noticed there's an increase in the quantity of food intake in each meal. That is, from 1 chapati in each meal, the child used to eat now 2 to 3 chapatis. And there's also increase in frequency of 3 to 4 times, but still the satiety is not achieved. The child was also having difficulty in walking 6 months ago, which is associated with pain, but it is not associated with any fever, any limping, trauma. It is not associated with any breathlessness. In negative history, we asked, there was no history of any headache, irritability, seizures, or any other neurological insult. There was no history of food-seeking behavior like stealing the food, binge eating, or eating food left over by others. There was no history of any drug intake like glucocorticoids, any antipsychotic, any anti-epileptic. There was no history of any polyuria, polydipsia. There was no history of any fatigue, exercise intolerance, constipation, any cold intolerance. There was no history of any head trauma. There was no history of any fever, pain, night sweat, weight loss, and there was no history of snoring at night. In antenatal history, the first trimester was uneventful. In second trimester, history of GDM was present in mother and took insulin for the same. History of PIH was present and took labetalol for the treatment. But there was history of decreased fetal movement at 5 months of gestational age. In third trimester, there was history of leaking per vaginum and preterm labor pain at 7 months of gestation. In birth history, the baby was born to a 28-year-old woman, G2P1 mother, at 28 weeks of gestation due to preterm labor pain by the preterm vaginal delivery. Baby didn't cry immediately after birth, and the Apgar was 3 at 1 minute and 5 at 5 minutes. Weight was 700 gram, which is at mean according to Intergrowth 21 charts. Baby had a history of NICU stay present for 1 month 10 days. The baby was discharged, and at the time of discharge, the weight was 1.3 kg, and it was discharged on OG feeding, which continues till 4 months and later shifted to Palladi feeding. In developmental history, the gross and fine motor milestones were delayed. Social milestones were initially delayed, but they came to be then normal with the age, but language milestones were delayed. So the developmental quotient for gross motor was 50%. For fine motor, it was 50%, but the social milestone was achieved as per age, but language milestones were delayed, that was 66%. So developmental quotient comes in around 66.5%. In dietary history, baby was on express and formula feed till 8 months of age, and then the complementary feed was started at around 8 to 9 months of age. At present, through the 24-hour dietary recall, the total calorie intake was 1660 calorie, which states 563 kilocalorie extra per day. This is the breakup we have taken for the calorie of breakfast, lunch, dinner. The total protein intake was 52 gram. There was 40 gram extra protein intake per day. There was a total fat intake of 47 gram, which is 25 gram extra fat intake of per day. In family history, the family is a type of a nuclear family with 4 members residing in a temple, as the father is a priest. There was no history of any same or other genetic disorder which is present in siblings. There is no history of abortions or stillbirth, but there is a history of obesity and GDM present in mother. This is a family pedigree. No other family members is being affected. Just one child is being affected. That is our case. In immunization, the baby is well immunized as per age. In socioeconomic, according to Kuppuswamy scale, the total score was 17 and family belongs to upper middle class. They live in a temple with 2 rooms, and the father is educated up to 12th class. The house has mother is up to 10th class. The house has 2 living rooms with separate bathroom and adequate ventilation is there. So we came to summarize history. A 3-year-old child born out of a non-consensuous marriage with complaints of weight gain and difficulty in walking. Baby was preterm, 28 weeks, 700 gram, preterm vaginal delivery with history of NICU history present for 1 month, 13 days. History of infantile hypotonia present, which resolves at around 8 to 9 months of age. And after that, a complementary feeding that started. History of hyperphagia and weight gain present with global developmental delay. When coming to vitals, yes, sir, yes, sir.
Go back.
Yes.
Any takeover here based on history? Anybody wants to tell your diagnosis? Ashish or any other panelist? Just keep the summary of the history. So in the examination, try to come to conclusion at history level itself. What are your differential diagnosis? Anyone? Other people can put your answers in chat box. Our panelists, they can. Second thing, you want to think here, generalized hypotonia or localized hypotonia. Where is the problem? There was the infection of CNS.
Hello, Sumit.
You have to think.
Yes, sir. Yes, sir. Hello.
Why did you ask about polyuria and polydipsia?
Sir, to rule out any hypothalamic disorder, to rule out diabetes insipidus.
Presenting as preterm delivery, hypotonia, and then hyperphagia.
Yes, sir.
Okay.
Doctor, you said excess, like Dr. Vijay Kumar said, excess thirst and urination in an obese child. What would you think of? Would it be diabetes insipidus or what?
Diabetes, any other thing?
Do you know the comorbidities of obesity, Dr. Sumit?
Yes, sir. Yes, sir. Yes, ma'am.
So what are the comorbidities of obesity that can present with excess thirst and urination?
Ma'am, the obese patients are more prone for type 2 diabetes.
Yeah, excess thirst and urination is a sign of diabetes.
Mm-hmm.
So, I mean, in an obese child, maybe this child is too young, not necessarily PWS. We need to think of any glucose metabolic defects.
Yes, ma'am.
Obesity with central diabetes insipidus, we will think of, some pituitary issues like, say, multiple pituitary growth hormone deficiency, like in interrupted. Some of them have growth hormone deficiency also, so they can be chubby. So
Yes,
when
ma'am.
you think of diabetes insipidus, we think of other things. Whereas in obesity, in an obese child with excess thirst and urination, we think of diabetes.
Yes, ma'am.
Mellitus.
Yes, ma'am.
Yeah. And you said difficulty in walking.
Yes, ma'am.
Can you elaborate on that?
Ma'am, it was also the main concern of the parents, since there was a difficulty in walking was present, but the weight gain was present from 1 year, but the difficulty in walking came in around 6 months. So we suspect maybe there is a, since the weight is more.
Can you go back to your motor history again? Kindly project your motor milestones. Yeah.
Yes, yes.
Tell about.
In the motor milestones, as we can see, the neck holding came at around 6 months. The sitting with support came at
Yes, sir,
1 year.
we want, just a second. Here your case is small kid. So we want from in the newborn state, newborn after 3 months, what was the progression we wanted? And while changing the nappy, while holding just after your discharge from the newborn. We're telling from 6 months, we wanted from the birth. What are the motor milestones? Hypotonia, how do you diagnose during first week of life or in preterm? So preterm themselves have a hypotonia, you know already. So
Yes,
How to
sir.
differentiate.
Sir, can you please repeat?
What is correct for the, we should, till what age do we correct for the developmental milestones in a preterm?
Ma'am, till 44 weeks, you will take a corrected gestational age.
40 weeks, no?
Yes, ma'am, 40 weeks.
40 weeks. So that's a corrected gestational age. Up to 2 years, we do that. And then we don't do, we don't calculate for corrected gestation age.
Yes, ma'am.
Yeah. So this child
then-
is beyond that. You can. Yeah, and-
we can elaborate in the examination part about this hypotonia entity. Go ahead with the example. Thank you.
Okay. Yes, sir. Should I go ahead with the vitals, sir?
Yeah.
Just one question before you move on to that.
Yes.
Yes, sir.
Sorry, I came a little late, but did you mention?
Yeah, we welcome Dr. Ravinder, the associate professor from PJ, and he's also coordinator for, and he's also from the executive board. We welcome Ravinder, sir. Please go ahead.
I just wanted to ask whether you mentioned about feeding difficulties in the newborn period.
Yes, sir. Yes, sir.
Early infancy, did you mention that?
Yes, sir. Yes, sir.
Why is that?
In, sir, since the baby was hypotonic, preterm, or the baby was also preterm.
Good, good. Okay, that's all. You can go ahead with the examination.
Ragupati sir, I expect you to tell 2 words regarding the you got late. Sorry.
Later.
Okay, right, after this.
Should I go ahead, sir?
Yes,
Yeah, please.
Thank you, sir. So baby appears well, conscious. She was playful and was examined in supine position and was comfortable. BP was 108/72, which is measured in right upper arm supine position, which comes in around more than 95th centile, but less than 95 plus 12 centile. So it denotes stage 1 hypertension. The baby was having a stage 1 hypertension. Child was having. The pulse rate was 100 per minute in right radial artery, regular in rhythm, good volume, normal in character. There was no radial, no radiofemoral delay. All the pulses were well felt. The respiratory rate was 20 per minute. In general examination, the child was obese. The child has an upslanting palpable fissure. There was almond-shaped eyes, hypertelorism, and also had mild strabismus. There was a thin upper lip and downturned corners of her mouth, giving a fish mouth appearance. Her hands and feet were small. Acanthosis nigricans grade 4 is present. In ENT examination, there was no tonsillar hypertrophy, and it was within normal limits.
So, doctor, just 1 second.
Yes.
I don't
Yes, ma'am.
remember you mentioning any, I might have missed it. Any history suggestive of sleep disordered breathing? Did you elicit in this child? In any of these child we elicit?
Ma'am, there was no any sleep. There was no history of any snoring or no any complaint of that. Therefore, but we have done for ENT examination. We have gone, and it was normal.
Okay. So history of sleep disordered breathing, we can ask snoring, respiratory pauses, restless sleep, daytime somnolence. So
Yes,
these
ma'am.
are the questions we can.
Yes, ma'am. So these are the pics we have. These are the almond-shaped eyes. I'll go with the anthropometry after I show you. After I give you a brief idea about the patient. This is a our child. We do not remove the t-shirt or the patient since the parents were not willing. We have also covered the eyes since parents were hesitating. Child was also. This is the acanthosis nigricans. We can see. It is also extending. It is also seen from. It can also visible from the front. This is a small hands and feet acromicria. Now comes to the anthropometry. The weight of the child was 32.5 kg, and the weight for age was plus 5.4 standard deviation, which is more than 97 centile. Height was 90 centimeter, and height for age was less than 2.5 standard, less than 2 standard deviation, below third centile. The weight for height was plus 8.2 standard deviation, which is more than 97 centile. Waist circumference was 88 centimeter, which is more than 95th centile. BMI was 30.6, which comes around plus 8.13 standard deviation. Upper lower segment ratio was 1.03. We've also calculated bone age. The bone age was 1 year 6 months, while the chronological age was 3 year 8 months.
Just go back.
Yes, sir.
Yeah. Yeah, put the growth chart and you can tell about that. You are telling. So based on the weight age, height age, and bone age. So what are the your differential diagnosis based on the anthropometry of the table? Yeah, show in the growth chart.
So here we have plotted her weight and height. Since height is 90 centimeter, weight is 32.5. The height is less than minus 2.5 standard deviation, while the weight is more than the weight is around plus 5.4 standard deviation. According to this, the bone age is less than height age, which is less than chronological age. This is the weight for age.
Also.
Just
What
to
is
go back,
weightage?
you have missed the weightage.
A weightage you
So-
have missed.
Yeah, very, very important. So the child is chubby and short. What are your
Where the
differential
weightage
diagnosis?
comes?
Yeah, here it comes, please. Tell us. It is more than the chronological age. It will come in the end. So your weightage is around
8 years, sir.
36. Yeah.
So it is
So
more
now
than
you tell the
chronological
differential
age.
diagnosis here. What are your differential diagnosis? Short and
Since
chubby
the
child, what do you think of? Yeah.
So since the bone age is more compromised in height age than chronological age, we'll go for any endocrinal disorder. We'll think of endocrinal disorder.
Apart from this endocrine,
But Dr. Sumit,
Yes, ma'am.
child who is obese with and the height less than the range of normal with dysmorphic features,
Yes.
what would you think of? Would you think of an
Yes.
endocrine or a
Or
syndromic
Genetics.
cause?
Syndromic.
Syndromic course, ma'am.
Okay.
Any other? Can you just mention few more examples of syndromic obesity?
Yes, sir. There are so many. There are Turner syndrome.
Obesity.
What's with obesity?
more
Ma'am,
common
sir,
than
leptin deficiency,
Biddle-Barrett syndrome.
Bardet-Biedl syndrome, Carpenter syndrome, Elstrom syndrome,
more
Okay.
common
Rohat,
than that. You are telling all rare things. Down syndrome.
Down syndrome, sir.
Right. Even skeletal dysplasia. You should
Yes,
think
sir.
of these three differential diagnoses. So one is genetic syndromes, then skeletal dysplasia. Third one is your endocrine. Very good. Go ahead.
Thank you, sir. This is the graph. This is the chart we have plotted of weight for age is more than 5.4 standard deviation. Weight for age is around more than 97 centile. The height is height is less than third centile. This is the weight for height which comes more than 99 centile. And this we have taken a reference of abdominal waist circumference which is more than 95th centile. This is waist to hip ratio which is more than 95th centile.
How do you measure the waist circumference, doctor?
Yes, ma'am.
Can you just explain to us how you measure the waist circumference?
Ma'am, at the level of pubic symphysis. Pubic.
At the level of pubic symphysis? There are,
Hello, ma'am, at the level of sorry, ma'am. I'm at the level of umbilicus. We measure it.
yeah, actually between the lower margin of the rib and the anterior superior midway.
Between
Anterior
the
superior.
yes, ma'am.
Yeah. Okay. Yeah.
Sorry.
Go ahead.
In systemic examination, the cardiovascular examination was normal. In respiratory parts, there was no any abnormality. Normal vesicular breathing was present with bilateral air entry. In CNS examination, the higher mental functions were normal. Cranial nerve examination was also normal. Upper limb tone, power, reflexes were normal. There was no sensory disturbances. But tone in lower limb cannot be assessed due to pain in lower limbs. In abdomen is non-distended. This umbilicus is central, inverted. There was no organomegaly. Bowel and bladder habits were normal.
Hello, Amit, Sumit.
Yes, sir. Yes,
I
sir.
think you could have discussed something about upper respiratory system also in this stage. Tonsils, the sleep
Sir,
apnea, all this pattern.
Yes, sir. Sir, we have done a ENT examination, so there was no any tonsillar hypertrophy was there.
So you can examine yourself. That may be in this case particularly.
Yes, sir. Yes, sir.
What do you expect in this case, Sumit?
Sir,
What do you expect? Yeah.
in examination, sir.
Yeah.
Sir, there may be in CNS examination there may be some find like speech articulation should be.
No. Upper respiratory only they are asking.
Actually, in upper respiratory, sir. Sir, tonsillar hypertrophy should be there or any adenoid hypertrophy.
And even obstructive breathing pattern, you can see like oral breathing. Madam was telling. It's a very
Yes, sir.
important point. Yeah.
Yes, sir. On investigation, the HB was 10.2. The total leukocyte count was
Before
around
going
30.
to investigation, we want you to, after examination, what is your diagnosis? First history, after examination, what you are thinking? Narrow down to your diagnosis, differential diagnosis. Then we'll go for it.
Sir, can I go to differential diagnosis?
Yeah, here only. Afterwards,
Yes.
Yeah.
So, sir, these are the differentials. The first was exogenous. The first is exogenous obesity, as is a history of GDM and obesity present in the mother. So, child was obese, but the points are against of exogenous is child is their syndromic child, and the height age is more compromised than weight age, and there's an early onset of obesity.
So, exogenous obesity, what will be the difference in height age? How will you differentiate between exogenous and endogenous or syndromic obesity based on the height centile?
So the height is height comes around height. The height will not be compromised in that patient, and height comes around 50th centile.
Very good. More than 50th centile, less than 50th centile for the target. Very good.
I think you can give first possibility as syndromic obesity, then exogenous obesity, maybe better. But
Yes, sir.
But should be in the end. Exogenous should be in the end.
Maybe in the
already in history level itself you have said, and at the level of even anthropometry also you have said.
Yeah,
So
I think
don't
maybe
confuse
syndromic
yourself.
obesity may be the first diagnosis. That may be better.
Yes, sir.
Sumit,
Yes,
I
ma'am.
had a question. You said the child has been having difficulty in walking over the past 6 months. A child who was walking fairly well began experiencing difficulty in walking about 6 months back. Isn't that what you said? And that you couldn't examine the lower limb because of pain. Can you tell us a little about one thing? I have two questions. Can you tell us a little about the pain threshold in Prader-Willi syndrome? And second thing is, when there is pain in the lower limbs and difficulty in walking, what will you look for in a PWS child?
Ma'am, we'll think of slipped SCFE, slipped capital femoral epiphysis due to as a child is obese. We'll also look for scoliosis or any skeletal dysplasia.
What is the hip joint like in a child with Prader-Willi syndrome? Hip joint.
Ma'am, in hip joint, we'll go for SCFE. We'll see for SCFE.
Yeah, there is developmental dysplasia of the hip.
Of hip. Yes, ma'am.
So that may look like a dislocated hip on X-ray. Because
Yes,
it's dysplastic. So we have to be careful. So when a child starts limping and having difficulty, we need to, did you examine the hip joint, the range of movements and all that?
No, ma'am, due to pain, we were unable, the child was also somewhat shy, but somewhat restricted movement was there.
Yeah. And the hypotonia, children with PWS, the hypotonia remains. It doesn't go away, if I understand. It improves, but it still remains.
Yes, sir.
Okay, ma'am. Ma'am, somewhat the tone was less only, but
Ma'am, in the upper limb, it was looks like normal because the reflex were normal.
So here, Sumit, here you need to take think of thought because you are not examining the child properly beforehand. It's, like 6 months back or 1 year back, and now you are telling about the now. So whenever you are comparing, according to age, you need to compare. Second thing, you need to do developmental examination or the bone examination in detail. So it's a CNS case, long case. They will ask each and every joint and muscle. Very good
Okay.
presentation. Go ahead.
Yes, sir. Sir, should I go with differentials only?
Yeah, go to your investigations. So you
Yes,
differential diagnosis only two. Tell what it. One is BWS, what else?
So the another is we can go for Prader-Willi-like syndrome.
Yeah.
The difference between two is just like in the, if we have like if we have genetic approval, like if we have gone for a genetic diagnosis and we have proved that there's a methylation at 15q11.2 q13, then we can say Prader-Willi. But still we don't have reports, we will go for Prader-Willi-like syndrome. In differential, we can also we also have leptin deficiency since the child is obese, hyperphagia is there, but there is a develop. So points in against of this, there is a developmental delay. The child has a global developmental delay.
One more question.
There is one more.
In which syndrome, short stature with obesity, as age increases, the tone will increase. What is that syndrome?
Sir, can you please repeat the question?
Short stature, obesity, with mental retardation. As age increases, tone will improve. What is that syndrome?
Tone will improve.
Where is the student?
Most common. I only mentioned. We said.
Sir, Down syndrome.
Very good. Very good. Yeah, go ahead.
We have one more differential called as ROHAD. That is rapid onset, hypothalamic dysfunction, hypoventilation, and autonomic dysregulation. The points in favor is the child is obese. Early onset obesity is there, but the on investigation we can see like will go before. So hypothalamic hormones are normal. There is no any history of any. There is no any complaint of hypoventilation. There is no any autonomic dysregulation. So we have ruled out the ROHAD also. Should I go to the investigation, sir?
Till last 1 minute is there. Tell the summary fast.
So it's a 3-year-old female with complaints of weight gain. It's a 3-year-old female with complaints of weight gain and difficulty in walking with positive history of infantile hypotonia, hyperphagia, and global developmental delay. On examination, the child was short stature, obese with dysmorphic facial features, almond-shaped eyes, fish-like mouth, acanthosis nigricans grade 4, and small hands and feet. On further investigation, child was hypertensive and was having dyslipidemia, but with normal thyroid function and other hormonal assay.
Investigation, genetic investigation results have come or not yet? They are awaited.
So genetic reports are still awaited.
If you want to tell anything about the metabolic syndrome, they are very much interested. If they have any findings, you can what is metabolic syndrome. Second thing, I wanted one more question on appetite. How will you differentiate the appetite of the Prader-Willi syndrome and exogenous obesity? Is there any difference?
Yes, sir. In Prader-Willi syndrome, the satiety is not achieved.
Due to what?
Yes, sir. Due to
What
say
is the
leptin
reason?
deficiency. Sir, here leptin levels are high, so in Prader-Willi, the satiety takes time to reach.
Something Madam was telling about the pain and all. Madam will be presenting it properly. Normal exogenous obese child, when you feed full stomach is full, you don't have its further appetite. So fullness is there, but here it is absent. Something to do with the pain and
Ghrelin hormone, sir.
fullness, yeah. Not related to
Ghrelin
hormone.
hormone.
It's the perception itself. Madam will tell about it. Thank you very much.
I have one more question, quick question.
Yes,
If I
ma'am.
can, Amarnath, can I ask?
Yeah, please.
Yes, ma'am.
Go ahead.
Sumit,
Yes,
did, did you mention anything about the genital appearance? Did I miss it?
Genital appearance, ma'am. Ma'am, genital appearance, no, ma'am. No, ma'am. Since
So
the patient,
since the patient is?
ma'am, since the patient was stable, we were unable to remove the top, that upper part. So we have not.
Okay.
What do you
Otherwise, there
expect?
is.
Yeah, you tell what do you expect?
Sir, hypogonadism, we should expect.
No, examination. Examination, what is the finding? Girl child, no?
Yes, sir. Sir, the breast, there were more fat over the breast areas.
Okay. No problem.
If the child would have presented in infancy, and any other differential you can think of, hypotonia, developmental delay.
Ma'am, it may be due to HI.
Hypotonia, okay. Anything else? Some muscular atrophy, spinal muscular atrophy can be one of.
Yes, ma'am. Spinal muscular. Yes, ma'am. Spinal muscular atrophy.
Why you have not kept hypothyroidism as a differential in this?
Ma'am, the hormonal assay was that thyroid. We have gone for investigation.
No. Just on clinical history and examination itself, not on investigation.
Ma'am, there was no. We have asked the history. There was no history of any cold intolerance, coarse facial features, coarse facial.
Okay.
We have completed the time. Now I request Dr. Madam to lecture or any other comments from the other experts. Kumar sir, Raghupathi sir, on examination and history.
Nothing.
On examination, that's about it. Maybe musculoskeletal, you could have looked for scoliosis or negative findings, observed for whether there was flat feet and whether, they do give ankle support. But of course, this child has started walking. Maybe she may need ankle support to walk better. We don't know. So those are some things maybe you could have mentioned.
Yes, ma'am.
And in the eyes, was there any squint?
Yes, ma'am. Yes, ma'am. Strabismus was there.
Okay. And yeah, I guess that's the thing.
Thank you, Sumit. Now I request Dr. L. Kavita Bhatt, Madam. He is Senior Consultant Pediatric Endocrinologist and Fellowship Program Director, Astor C. Madam is known her Prader-Willi comprehensive work in India. They got the special prize from the national.
No. My fellow,
Yeah.
got
Please
a
mention,
grant.
ma'am.
My fellow. Yeah. My fellow had applied for a grant and she got a grant from the Prader-Willi, International Prader-Willi Association. Can I share my screen?
Yes, madam, please. Visible.
Okay. Can you see it?
Yeah, go ahead.
Okay. So, Prader-Willi syndrome is a genetic disorder that occurs in approximately 1 out of every 15,000 births. It affects males and females equally and all races. It is the most common genetic cause of life-threatening childhood obesity. So this would be the outline of my talk. I'll just go a little bit into the genetics and later on the clinical features, most of which has been kind of touched upon in in Dr. Sumit's case presentation. And then a little bit about evaluation and treatment of this complex multidisciplinary system involved of this disease, which involves multiple systems. So a little bit of understanding of the genetics of Prader-Willi. It's a little complicated. You know, we have 23 pairs of chromosome, 22 pairs of autosomes and one pair of sex chromosome. One chromosome of each pair is inherited from the father and mother, and the chromosomes are made up of genes. So each gene has two alleles. One is a maternal allele and the other is a paternal allele. Now, generally, in most instances, in most of the genes, both the maternal and paternal genes are expressed. So that is called the non-imprinted genes. So most of the genes in our body are non-imprinted, meaning both maternal and paternal genes of the maternal alleles are expressed. Now, what is imprinting? Imprinting is, it's an epigenetic phenomenon, meaning it doesn't follow the Mendelian inheritance. It's an epigenetic phenomenon wherein methyl groups get attached to the DNA molecule of either the paternal or maternal gene and silence it. So imprinted genes, when the maternal gene is silenced through DNA methylation. So when a when a gene goes, when DNA methylation happens to a gene, it's silenced, meaning it doesn't express. So if the maternal gene is methylated, then only the paternal gene is expressed. If the paternal gene is methylated, then maternal gene is expressed. This happens at the level of germline and not at the level of meiosis, which results in Mendelian inheritance. So in Prader-Willi syndrome, this is what happens. There is a region of chromosome 15, 15q11 to q13 region, wherein the maternal genes are silenced or inactivated by methylation. And hence, only paternal genes are expressed. So Prader-Willi syndrome, so this is the normal chromosome wherein only paternal genes are expressed, normal chromosome 15, but maternal genes are silenced, fair enough. So, but what happens in Prader-Willi syndrome is that there is loss of this paternal gene due to a large deletion. So there is no allele that can be expressed because the maternal allele is silenced by methylation and paternal allele is lost through deletion. There are certain instances, during the meiosis and the non-disjunction that happens, that the zygote can inherit both the chromosome 15 from the mother. And we know they are silenced. Maternal genes are silenced in the chromosome 15q area. So this is kind of, there is loss of paternally expressed genes even when there is uniparental disomy. Uniparent meaning only the maternal genes are inherited, which are anyway silenced by DNA methylation. Then there is an imprinting center in the Prader-Willi syndrome, the segment. So sometimes there could be mutations or there could be small deletions in this. So this is the only condition wherein it could be inherited. Otherwise, Prader-Willi syndrome, by far in most instances, the risk of recurrence is as much as the general population. It's only when there is an imprinting center deletion that it can follow the Mendelian inheritance, and there could be a 50% chance of it recurring in the next pregnancy. So that is called the imprinting defect. It could be a mutation or deletion. And deletion is the one that could recur in next pregnancies. So it's very important to accurately figure out the molecular type of Prader-Willi syndrome if the family is planning to go ahead and have the next child. So the diagnosis, there used to be a PCR-based DNA methylation study But these days, MS-MLPA is preferred because it picks up both those small deletions which tend to recur in the imprinting center, plus those large deletions in the paternal chromosome 15q13 region. However, it cannot distinguish uniparental disomy from an imprinting defect by mutation. You know, the imprinting center defect can either be due to a deletion or a mutation, but MS-MLPA cannot differentiate between the two. So if you all suspect Prader-Willi syndrome, the one test that you would do is an MS-MLPA, which will detect almost all cases of Prader-Willi syndrome, and also help us figure out the genetic subtype in a major percentage, especially the genetic subtype that could recur will be picked up in MS-MLPA because the small mutations in the imprinting center are picked up in MS-MLPA. Now, the cardinal clinical features has been covered very well by Dr. Sumit. So, as pediatrician, we need to have a high index of suspicion and send the test as early as possible, because early intervention is very, very important in Prader-Willi syndrome. It can change the natural history of Prader-Willi syndrome, early intervention. It's important that we have a high index of suspicion. If there is a prenatal history of reduced fetal movements, and if it's a breech presentation, there has been polyhydramnios. So that is an early indicator of a hypotonic infant in the uterus. In the newborn period, most of these babies are born with hypotonia and poor suck. They have immense difficulty in feeding and they sleep most of the time. The hypotonia is what makes it difficult for them to suck. And often for a short period of time, they may have to resort to nasogastric feeding. At the age of, between age of 1 month to 2 years, failure to thrive, developmental delay should prompt us to do the genetic test. So between the age of 2 to 6 years, if a child presents with developmental delay, then we need to ask for a history of hypotonia with history of poor suck, feeding difficulty, reduced fetal movements. And if these kind of things are present, we need to think of PWS. When they're 6 to 12, usually by that time, this hyperphagia would have set in. So they gain weight rapidly because they do not feel full. And in fact, I think for when it comes to management, I'll tell, but I would like to tell a few points here. We counsel parents extensively on how they should structure the meals and eating space, control the environment very strongly in these children. So again, if there is a history, if a child of 6 to 12 years comes with obesity and you have elicited history of excess eating and the child has not attained age-appropriate milestone, there is a history of hypotonia we need to think of. So these are all the clues that should prompt us to do a genetic test. Now, clinical characteristics are quite a few because it's a multisystemic disorder. Hypotonia is universal. Difficulty in dysphagia, difficulty in swallowing is also universal in a large percentage of patients. In fact, some of them could have reflux, silent reflux also, and that is dangerous. It still persists to adulthood. And this is worsened because they have reduced, children with PWS have reduced saliva. So to swallow is, the swallowing difficulty is aggravated because of that. Motor delay because of hypotonia, language delay, intellectual disease, and a multitude of endocrine manifestation because of the hypothalamic dysfunction, like hypogonadism, which manifests in the newborn period as micropenis, cryptorchidism. So we see a newborn baby who is hypotonic, who has micropenis and has cryptorchidism. We need to think of Prader-Willi syndrome as one of the differential diagnoses. These children could have premature adrenarche. They do enter puberty, but then they do not progress. So it's an abnormal pubertal development. they have growth hormone deficiency, and they are prone to developing diabetes mellitus, especially type 2. They can have hypothyroidism. So we need to screen them. There's a protocol for screening them, for the occurrence of these, and even central adrenal insufficiency is known to occur in a certain percentage of children with Prader-Willi syndrome. The hyperphagia and obesity typically starts at around 3 years. It begins as an interest in food. You know, even children, before they're able to talk, the parents say that the child's eyes go towards where food is. I mean, this is something that I've heard parents say of young children also. If suppose somebody is eating or some food is kept somewhere, they're constantly looking at it even before they can express it. So their interest in food is very high, and obesity sets in very rapidly. These children have an element, I'll come to that when we are in the behavioral characteristics. They tend to have an OCD kind of picture. So they respond very well to a scheduling, regimented, when they know what to expect. And it's recommended that when we change the schedule, we inform them well ahead. Otherwise, that can precipitate a tantrum if you change their schedule. And managing weight gain is easier when they know when to expect their meals, and that thing is adhered to. So, and we counsel parents not to use food as a reward or punishment in these, not only in these children, it should never be used in any child. They have a characteristic behavioral profile. They are prone to anxiety, and that's why they keep asking. You know, if you see a child with Prader-Willi syndrome, he will, if he wants an answer, he'll repetitively keep asking the same question, which is a reflection of the anxiety. And then if they do not have the ability to self-regulate, so that they throw tantrums, they're very rigid, they have OCD features, they can be very manipulative when it comes to food intake. Some of them have autistic features. Psychosis is more common in uniparental disomy as well as ADHD. So we need to, when we evaluate a child, when a child with PWS comes to a clinic, we need to spend a lot of time actually going through asking for all this so that we can intervene early. So again, there is, it's okay, this next, sorry. So there is a pattern of growth weight gain, which I think we have all alluded to. It's basically initially there is hypotonia and feeding difficulty and poor growth. And then there is a phase wherein it's easy to feed them and they grow adequately. And then they gain weight without a change in appetite. And then their appetite increases and their interest in food increases. Evaluation, we can evaluate the newborn and young infants for sucking issue and poor growth, and they need to undergo a nutrition consultation because they have failure to thrive. They should have a rigorous physiotherapy evaluation, and of course, every child with hypotonia we screen for presence of hypothyroidism. Now, one thing, we work with our physiotherapy team because physiotherapy in hypotonia in Prader-Willi syndrome is different from physiotherapy techniques in other causes of hypotonia. So these children, if they are made to sit very soon, they should never be made to sit until they are sitting up on their own. Whereas if we don't say that, physiotherapists try to make them sit, and that is a way to precipitate scoliosis in these children. So we need to discuss with the physiotherapists and plan out a physiotherapy regimen, keeping in mind that they should not follow the typical protocol for physiotherapy. They should never ever force the child to sit and make this child sit, be in a hurry to make the child sit. So everything starts after the child has started sitting up on its own, which is delayed and which happens at an average age of 12 months. So there is developmental assessment that needs to be done and developmental interventions. Hypogonadism, like I said, in the newborn period, there could be micropenis, cryptorchidism, and they need to be assessed for this, and pubertal staging during puberty.
No.
Endocrine, growth hormone deficiency, diabetes, hypothyroidism, we need to assess for central adrenal insufficiency. There is a hyperphagia questionnaire which can be maintained and plotted. And we need to monitor many of these things. So this basically requires a multidisciplinary approach. It's not just one of us, it's quite a few of us that need to work on these children. So what we do is we share the consensus guidelines with our other partners in care. Physiotherapy, we give them what is the latest consensus guideline on physiotherapy, or there are PDFs of physiotherapy that has been done. And then we sit with them and chart out a plan for our patients on how we can early intervene. We start, maybe the treatment part of it. So scoliosis, we need to assess for hip dysplasia objectively by doing a hip ultrasound. And some of them have seizures, which is easy to, which is not that difficult to treat. They are at increased risk of caries because their enamel is hypoplastic as well as they have less saliva. And of course, genetic counseling. Most parents are worried about recurrence. And if MLPA does not show, MSMLPA does not show the deletion in imprinting center, the chances of recurrence is the same as in general population. So the treatment, most of this we have covered. I would just like to dwell a little bit on the hypogonadism part. There is a phenomenon called mini puberty in the newborn, which is there in the first 6 months for a male baby. So that mini puberty is not different in children with Prader-Willi syndrome. They undergo normal mini puberty, but then the true puberty at the teenage years, that does not go on as expected. Though they enter puberty, there is a pubertal arrest. So we need to give HCG treatment for cryptorchidism. There are several studies, and now this is a standard. If a child who is less than 18 months comes to you with cryptorchidism, please consider HCG treatment. And occupexy can be done because this can increase the testicular volume and also sometimes bring it down. In between, during the course of a pediatric endocrinology career, HCG treatment in infancy had fallen out of favor, but in Prader-Willi syndrome, we still need, it's been found to be beneficial. So during puberty, during the time of puberty, we need to do the sex hormone replacement. But again, there is always a fear of it aggravating all the aggressive behaviors. But if we don't do the estrogen or testosterone replacement, there is a possibility of osteoporosis, which is very, very high in PWS because of the hypotonic muscles, the bones are weak, and their hypogonadism, growth hormone deficiency all contributes to very weak bones.
Madam, you have 2 more minutes.
Okay. So growth hormone treatment, the earlier we start, early in infancy is the best because it has been found to help cognition, and it's one molecule that changes the natural history of Prader-Willi syndrome. In fact, the International Association for Prader-Willi syndrome has recommended that it be continued in young adulthood because it benefits them. The dose is much less than that recommended for children. It is important to obtain a sleep study before and after starting treatment, and serum IGF-1 value should be kept below +2 standard deviations from the mean. So this is how we need to monitor them. Dietary management, again, a well-balanced, low-calorie. In fact, they need only 60 to 80% of the calories that same age children need, even to maintain, even for weight maintenance. So at that low-calorie level, there is a chance that they end up with vitamin and mineral deficiencies. So we may want to think of giving a multivitamin supplement just to be on the safer side. Controlling environment by locking everything is very important. In fact, they are grateful to it because there is no hope. When there is no hope, they are better off, their behavior and everything. So skeletal issues, we work with our orthopedic surgeons and we need to make sure that calcium and vitamin D supplementations happen. We need to give all the hormone replacement therapy to prevent osteoporosis. So there are multiple other things. So what is a multidisciplinary approach to deliver comprehensive care is important. Thank you.
I thank you very much, Dr. Bhatt Madam, and also Dr. Sumit and guide Dr. Seema. Thank you very much. Excellently presented. Now, I want any comments from Raghupati sir.
Just wanted to mention about hypogonadism. The patient was a girl, and so hypogonadism was not mentioned there. Hypogonadism in girls can be made out by hypoplasia of the labia minora. Hypogonadism does occur both in boys and girls. So one of the things is to look at the genital exam and make out whether there is hypoplasia of the labia minora. And to summarize the genetic findings, 75% of cases are due to deletion in the long arm of chromosome 15. 20% it's uniparental disomy, and the rest is due to a methylation defect. A methylation analysis will pick up all the three forms of genetic abnormalities. That's all I would like to say, and I would like to also express my sincere pleasure in seeing the continued interest in pediatric endocrinology among postgraduates in pediatrics. What we started as a small effort is now regular and is evincing a lot of interest. Thank you.
Thank you very much. I request Dr. Seema Rai, who is a guide for this case, to say a few words. Dr. Seema.
Good evening, sir.
Yeah.
At first, I would like to extend my gratitude for this wonderful opportunity and continuously guiding throughout the case allotment and till now. And in today's session, we learned a lot. Like we actually mixed how, because the child was female, so how to assess hypogonadism was missed on our part. So that is a very important learning point for us. Rest of the things we'll keep in a follow-up track, and we'll definitely update when we receive the genetic reports as far as this child is concerned. Thank you, sir.
Thank you very much. Thank you. Now I request Dr. Ashish to proceed for the next case presentation. So, guide is Dr. Anjali, madam. She is associate professor. Madam is from the PGIMS Rohtak. So, for this case presentation, external examiner will be Dr. Vijay Kumar. He is a professor and head of the department from Calicut Medical College. Over to you, sir.
Hello. Good afternoon, Dr. Ashish. I think you can present now.
Thank you, sir. Good evening, everybody. Myself, Dr. Ashish, Junior Resident, Department of Pediatrics, PGMS. I'm presenting case on growth hormone deficiency, and my guide is Dr. Anjali Verma, Associate Professor, PGMS Rohtak. So here my patient is Himanshu, 8 years, 7 months old male child from Bhiwani, Haryana. Informant is mother, who is reliable, and chief complaint was inadequate gain in height and weight for the last 3 to 4 years. History of presenting illness. Patient noticed that their child is not gaining both height and weight appropriately for the last 3 to 4 years. Mother sought treatment multiple times from mainly treated with multivitamins and other supplements. Sought when comparing to other boys and peers children in the same age group. Used to stand in the first row during a school prayer meet, not outgrowing his clothes shoes for a long time. Permanent dentition has not started yet. Younger sister is taller than him, and weight gain is extremely low when compared to his younger sister. Negative
So what
history.
is one question? What is the importance of this permanent dentition?
Dentition is delayed in this case. Maybe in growth hormone deficiency, there is delay in permanent dentition, sir.
Okay. Okay, continue.
No history, negative history, no history of increased frequency of.
Dr. Ashish, one more point. You said about the height and weight.
Yes, sir.
Can you differentiate between which is the prominently they are worried? It's a very important thing.
So mainly they were worried about both, sir, because height and weight both were extremely low, sir.
So you want to think of malnutrition here when it is both are less?
No, sir. Actually, when we plotted on graph growth chart, height was mainly more compromised than weight, sir. So
you should ask the
It's
question.
still-
Then only they will tell. Yeah, go ahead.
I think still in our country, the commonest cause of the stunting and wasting are nutrition only, malnutrition
Nutrition
only,
only, yes,
both
sir.
macro and micronutrient. And
Yes.
sometimes the growth hormone deficiency may be associated with, there may be multiple causes.
Yes, sir.
Since the weight is source, you have to go deep into the nutrition system. Anyway, we can see the general examination.
So in this pic, we can clearly see that our patient.
Continue.
Okay, sir. So in this pic, we can clearly see that our patient is standing next to a child who is of same age. In negative history, no history of increased frequency of loose stool and foul-smelling stool, no history of abdominal pain and worms in stool, no history of eating soil and paper, no history of excessive or decreased micturition, thirst and frequent vomiting, no history of prolonged cough, difficulty in breathing and recurrent hospitalization, no history of constipation, lethargy, dry skin, excessive sleepiness, no history of nausea, easy fatigability, decreased appetite, yellowish discoloration of skin, no history of bluish discoloration of lips and skin and giddiness, no history of headache, vomiting, visual disturbances, and no history of involuntary movement of limbs and muscle weakness.
What is the importance of involuntary movements and the muscle weakness?
This history was taken in view of maybe hypocalcemia due to pseudoparathyroidism.
Okay. Okay.
Can you tell any other features of pseudohypoparathyroidism? History?
So hyperphosphatemia, sir.
No, history wise.
History, so bone advanced bone is can you from
Dr. Ashish, we are asking history,
okay, so
not investigation. What will happen? The development, head size.
prominent.
Okay. Yeah, go ahead.
In past history, we have no history of any chronic illness in the past, recurrent infections and hospitalization, no history of any trauma, surgery and chemoradiation, no history of recurrent blood transfusion, and no history of long-term steroid intake or any antipsychotic drugs.
Okay.
In antenatal history, mother's age during pregnancy was 21 years, a spontaneous pregnancy, and it was not booked. There was history of 3 previous abortions at 2 to 3 months of gestation. A reason is unknown. Mother did not take iron folic acid tablets and approx 10 kg weight gain throughout the pregnancy. No history of any infection, substance abuse, and pregnancy-related complications was there.
So what all things you can gather from the antenatal history? Any points?
Maybe
what all things? Very important things.
History of previous abortions gives a history of maybe that there is some congenital chromosomal aneuploidy, sir.
Very good.
Yes, sir.
So you have to suspect. So you have to suspect some chromosomal
And you cannot-
anomalies in this.
Yes, anomalies.
And mother didn't take iron and folic acid tablet. Again, the chronic iron deficiency anemia may be a problem in this stage.
Yes,
So
sir.
this may be a multifactorial problem.
Yes, sir.
Continue.
Natal and postnatal history. Gestational age was full term. Birth weight 1.5 kg. Birth length not known. Mode of delivery breech normal vaginal delivery. No birth asphyxia. Feeding history. There is no difficulty there was no difficulty in feeding. No history of neonatal jaundice and no history of hypoglycemia and seizures.
So again, from this, what are the important points you can gather from this and natal history?
So from birth, gestation was full term and birth weight is 1.5 kg. So this patient may be a IUGR baby because
Yes.
small for gestational age is there. And mode of delivery, sir, is breech normal.
So what is the importance of this low for gestational age or low birth weight?
So
Usually, what will happen in a growth hormone deficiency and all?
So initially, so in a small for gestational age baby, maybe a baby may be of short stature due to poor catch-up growth.
Okay, so what I expected is, suppose if the child is having pure growth hormone deficiency and all, there is no point of the birth weight will be normal. There is no point that the child is having a low birth weight because growth hormone is not much essential during intrauterine period.
Yes, sir.
Here, the growth faltering might have started in the intrauterine period itself. So we have to be very careful just to diagnose growth hormone deficiency, and the treatment may not be that effective also.
Yes,
So you
sir.
have to suspect. Again, I think since the recurrent abortion history is there, birth weight is low, so you have to suspect again chromosomal anomalies,
These are normally, sir.
some other causes of intrauterine growth restriction, maybe sometimes intrauterine infections. So in the general examination, you have to be very careful to rule out intrauterine infections, chromosomal anomaly, and all these things.
Yes, sir.
Next thing is birth length not known. Why? So everywhere in India, they will take birth weight, but even in Kerala, it is like that. Birth length, you won't get that vital history, vital measurements in your history, past history, and all. That is a shame actually. For even in Kerala, it is like that.
Yes, sir.
And breech normal vaginal delivery. Breech is not a normal vaginal delivery. Can you tell this breech normal vaginal?
No, sir. Basically, it was a breech vaginal delivery.
Yes. So, what is the importance of breech?
So, many studies have shown that breech delivery is associated with hypopituitarism, sir.
Okay. Okay.
Yes, sir.
Okay. Good. Good. Go ahead.
Actually, I want to emphasize in this that the mother is specifically giving history that the patient is not outgrowing clothes and shoes for last 3 to 4 years. So although the height and weight both are affected, but this is the main history she is giving. So sir, that could be a pointer in the history which could indicate that the problem must have started 3 to 4 years back, not since birth itself.
Okay. Then the better thing is to see the previous height and weight standards. I think your growth chart will help you. So
Yes,
a detailed growth chart with height and weight plotted almost from the infancy onwards, that will give you an idea. Because
actually, sir, in India it is not available. That is
okay, we can see this growth chart.
Yeah, Ashish, what is that called? What sir is mentioning? What is that called? Which chart?
Which chart? Which
Yeah.
chart?
Sumit, any other PGs, please
No.
tell.
Like consecutive plotting on the chart. What
See-
charts you will use for
Yeah, serial height recording.
serial height recording? What you will call it as serial height recording, Ashish?
Growth
Something-
velocity chart.
Yeah,
Growth
Correct.
velocity.
very good, very good. Come on. Go ahead.
Shall I go to next slide?
Yeah. Next.
In developmental history, normal milestones attained at appropriate age. Now studying class first, got admission in lower standard because of immature appearance. Good in
So
study.
that what is your inference? Lower standard means when? So that may indicate that his short stature is very early. Even if his LKG, UKG, he might not. I think lower standard means primary school.
Basically, at this age, child should have got admitted in fourth class. But since child was by appearance, child used to look very immature. That's why the school denied to admit him in class
I
4.
think that is. I think there is significant short stature from early age onwards. We can see this growth chart. Then okay, we can go.
Okay, sir. In immunization history, immunized till date as per NIS schedule. In diet history, exclusive breastfeed till 6 months of age, and complementary feed started along with breastfeed after 6 months. And in diet history, calorie and protein deficit was not that significant. In family history, first,
Do you want to
I think
mention about
you have taken
Yeah.
any history regarding the micronutrients, iron, calcium, vitamin D, zinc. Everything is very important for height.
yes, from starting, I already explained that whenever mother used to go to hospital, then mainly child was prescribed multiple multivitamins and calcium, sir, for that.
Okay, continue.
And we have examined also, sir, that the child for micro.
Okay, examination we can continue later.
Yes, sir.
Continue.
Family.
These are the main important things. Always, whenever you get a case of growth hormone deficiency, also there may be associated macronutrient deficiency. You have to find out and treat them. Then only you will get a very good improvement, because just diagnosing growth hormone deficiency and treating with growth hormone may be not enough effective sometimes. Find out all these things, because we are living in a country where macro and micronutrients are very rampant. Okay. Moreover,
I
this
have one
is
question here, Ashish.
Yes, sir.
So, based on your nutritional history, he's taking normal nutrition almost, but
Yes.
still child is short and thin.
Thin.
Weight and height center. What do you think of based on history level?
So maybe the reason behind the short stature and not gaining weight is something else other than the undernutrition, sir.
What?
So like maybe, sir, it is some genetic disorders, sir. Or maybe
Malabsorption or celiac
maybe
syndrome,
genetic
celiac
disorder
disease.
or endocrine.
So he's taking everything normal, still absorption is not happening. That you should think.
Yes,
Okay.
In family history, first born to non-consanguineous marriage, no history of significant illness in the family, no history of short stature member in the family, no history of delayed puberty in father and mother. Two younger siblings are there of 7 and 3 years old, and no history of disharmony in the family.
Very good.
And socio-economic status belong to upper lower economic class family according to modified performance scale. Nuclear family living in concrete house, mother is housewife and father is working in private company. In general physical examination, alert and interested in surrounding, and rest of the general physical examination, it was normal. Vitals were normal. There were no palate, teres, edema, lymphadenopathy, and clubbing. In anthropometry, actual weight was 15 kg. That was below 3rd centile. Height 99 centimeter. That is again below 3rd centile. BMI is 15.30 kg per meter square, between 25th and 50th centile. And target height is 154 centimeter to 166 centimeter. That is again between 3rd and 25th centile. So
can you just see the growth chart will be there after this?
Yes, sir. Here
you'll be showing. Okay. Okay, you can go in the same order.
Okay, sir. So upper segment, lower segment ratio is 0.96. Arm span was 99 centimeters.
What is your suggestion? Upper segment, lower segment. What is your idea? No, this is proportionate or disproportionate?
So it is proportionate, sir, with this age.
What is the age?
So 8 years, 7 months, sir.
Okay. So
arm span is 99 centimeter. Father height is 160 centimeter. Mother height 147.5 centimeter. Mid parental height 160.26 centimeter. Target height is 160.25 centimeter, and no rhizomelic sorting, sir.
Okay, go ahead.
Here is the growth chart representing height age, weight age, and bone age, sir. So height is corresponding to 3 year 5 month. Weight is corresponding to 3 years 6 months, which is almost same, sir. And
okay.
Yes, sir. And bone age corresponding to 3 years, sir.
Yeah. So what is your
That
idea?
is seen
So
expression.
here, height age is 3 year 5 months.
Yes, sir.
Weight age is 3 years 6 months.
6 months. And
Okay,
bone
almost normal.
Yes,
Okay,
sir.
bone age is delayed.
Delayed.
Even less than weight height age by how many years?
Yes, sir.
Bone age is less than height age by 3 years. Okay, okay.
Yes, sir.
So what is your just explanation to all?
So here we can see that height age is much more compromised than weight age, sir, because it is much more lower than the third percentile in comparison to weight age, sir.
Okay. Okay, and bone age is also delayed. Okay.
Yes, sir.
Again,
Bone age
Sumit,
is also very much delayed.
Yes, sir.
you should think
So
of,
first possibility.
So bone age is
What is your
so
from based on this growth chart? What is your first possibility?
so weight is more than height age and more than bone age. So
Yeah.
most probably it is endocrinal region.
Very
The
good.
growth hormone deficiency or the panhypopituitarism, sir.
Okay. Can any other growth hormone deficiency come? Any other hormonal deficiency? Hypothyroidism?
Yes, sir. Hypothyroidism. Yeah.
Okay. So what will happen in a pure nutritional problem?
So in that case, sir, weight age will be height age will be more than weight age, sir.
Very good. Okay. Continue. But suppose I am telling this is a familial short stature. How will you argue against it?
So the height age is very much compromised, much more lower than third centile, sir. In case of familial short stature, it would have been parallel to third centile, and
Ashish, can you
Or
choose
at par with the
MPH?
target height.
MPH, target height.
What is the target height here?
so
You
here,
have plotted.
yes, sir. This is the target height.
He has plotted.
Height.
Yeah.
Yes, sir.
So
Here,
much below the target height.
much below the target. That's why it
Very
can
good.
be familial short.
And what will happen to the bone age in a familial short stature?
So bone age is equal to chronological age, sir.
Very good. Here, what is happening?
So here bone age is delayed, sir. Much more delayed.
Delayed.
Yes, sir.
Very good. Very good.
There is significant delay in bone age comparison to chronological age, sir.
Very good. Very good. So this has to be investigated.
Yes, sir.
Continue.
Here I have plotted, sir, BMI, sir.
Yeah.
Which is in between 25th to 50th centile.
Yeah.
So
Good.
on examinations, head to toe examination, a skull normal in shape. Here is normal. Frontal bossing present. Cherubic face or immature face is there. No obvious dysmorphism present. No midline defect. Eyes fundus examination is normal. No any sign of micronutrient deficiency. Ear and nose normal. No any neck swelling, and oral cavity is normal. No any cleft lip and cleft palate was there.
Very good.
Continuing with head to toe examination, no asymmetry of the body, no skeletal abnormality.
Can you give me any condition that will produce asymmetry of the body?
Sir, skeletal dysplasia, sir, and even in genetic disorders like Russell-Silver syndrome, sir, there could be asymmetry of the body. Yes, sir.
Because the child is having a low birth weight. So always think of, always think of.
Yes, sir.
If you get some clinodactyly or some abnormality in the face, think of a genetic problem because birth weight is less.
Yes, sir.
Good.
Chest is symmetrical, no abnormalities. Pot belly present, hand, forearms, arms normal. Skin, no dryness, no capillary spots, no navy, no stria. External genitalia normal. Stretch penile length was 5.3 centimeter within normal limit. Bilateral test is palpable, normal in volume, and no hypospadias, sir. Lower limb normal in appearance, sir.
Very good.
Sumit, one question here.
Yes,
Go
sir.
back. What are the causes of capillary spots and nevi with short stature?
Sir, internal syndrome or Russell-Silver syndrome, sir, and navy is there. So capillary spots, sir, in sir.
No, here male child. You want to think of Turner?
No, sir.
Nevi.
No, sir.
Noonan.
Yes,
So,
Noonan syndrome.
capillary
In case of
spots in
syndrome.
Russell-Silver syndrome, nevi in Noonan syndrome. Good.
Yes.
Stay in
Australians are exogenous iatrogenic conditions are like Cushing, Cushing syndrome.
very good.
Yes, sir.
Very good.
In systemic examinations, abdomen on inspections of pot belly present, which can we can clearly see in this picture, sir. CVS respiratory system CNS was normal. So overall,
Pot belly, if there is there any hepatosplenomegaly? No.
no, sir. No, sir.
Just pot belly. Okay.
Yes, sir.
Good.
So
Can you tell what is the cause here? Cause of pot belly?
Sir, adiposity, sir.
Very good. The distribution of fat,
Fat.
hormone deficiency, even in hypothyroidism,
Yes, sir.
mainly central.
Yes, sir.
Right.
Yes, sir.
Good.
So in summary, here is 8 years, 7-month-old school-going child with good performance in school, first born to a non-consanguineous parents with not gaining height and weight noticed for last 4 years. On examination, phenotypic feature of growth hormone deficiency like frontal bossing, cherubic face, pot belly, high-pitched voice, and proportionately pathological short stature. Severely stunted with height, affected more than weight, with normal genitalia, with no chronic illness.
Good.
So diagnosis here, pathological portion, yes, sir.
Yeah, we can continue. What is the diagnosis?
Pathological proportionate short stature, sir.
Hmm.
In differentials, we have a growth hormone deficiency, SGA with poor catch-up, malnutrition, malabsorption such as celiac disease.
Okay.
So differential
So
diagnosis.
why did you put growth hormone deficiency as a first diagnosis? So points in favor here, first diagnosis.
Yes, sir, because height is much more compromised and bone there is a marked delay in bone age, sir.
Very good. And some distinctive clinical pictures.
Yes,
of growth hormone deficiency.
yes, clinical pictures also, sir.
Just go back. I want to keep another 2 differential diagnoses along with this. One is growth hormone deficiency with SGA.
Yes, sir.
So both together. And third one,
Yeah.
something else with growth hormone can present just like this. What is that? Similar to this, except the dysmorphism is different. What is growth hormone excess? Growth hormone excess, what is called? Laron syndrome. Yes, go ahead.
So in differentials, growth hormone deficiency and panhypopituitarism, height more affected than weight. Frontal in points in favor of height more affected than weight. Frontal bossing, cherubic face, pot belly present. Point against where no sign. No signs, symptoms suggested hypothyroidism, cortisols, or no micropenis. SGA with poor catch-up, born full term with birth weight 1.
So one question: can it be isolated growth hormone deficiency rather than panhypopituitarism?
Sir, after doing some other lab.
That after investigation, before
Yes.
investigation.
Yeah, yes, sir. Child was not giving in history taking no any relation with hypothyroidism and Cushing-White syndrome, sir. That's why.
Yeah. No, but there is no micropenis
No, yes,
and
sir.
all these things. There is no history of hypoglycemia. A lot of things are there. But always, even if you diagnose isolated growth hormone deficiency, it can even develop panhypopituitarism later. So ongoing follow-up is essential in any case because most sensitive with a somatotroph. So you have to investigate later. But that is for the treatment purpose, whether it is a isolated growth hormone deficiency or we are dealing with a panhypo.
Yes, sir. So second differential one, SGA with poor catch-up, born full term with birth weight 1.5 kg. A child was gaining weight and height till 2 to 3 years of age and not growing after 4 years of age. Malnutrition, both weight and height less than 3rd centile. Calorie and protein deficit, point against height more affected. No signs symptoms of micro and macronutrient deficiency. Child was active and very playful. In celiac disease, points in favor, both weight and height affected, and point against height affected more. No history of anemia, loose stools, and IgTTG level were normal.
That is in the investigation only.
Yes, sir.
Okay.
Just one question on SGA. back.
Yes,
So
sir.
how much percentage of SGA will catch up and how much percent will have a food catch up? Normally, like in preterm babies and SGA, you are telling no.
So normally 25 to 40% babies catch up, sir.
No, even
No,
more
up to
than that.
80%, 75
Up
to
to 80 to
80%.
90%. 80% they will catch up.
Only 5 to 10 or 15%.
All the remaining 5 to 10%, you have to look for chromosomal anomalies or some other cause. Why the child is not catching up?
So in investigations, first we went for the X-ray left wrist. Bone age is around.
Always tell X-ray, not X-ray wrist, X-ray of both hand is enough.
hands. Yes, sir.
Wrist, don't tell X-ray left wrist, X-ray left hand.
Left hand, sir. So bone age is around 3 years.
Okay. That is, this is Grulich and Piles method.
Yes, sir.
Which method you have used? Grulich and Piles or?
So basically on a bone
How did you assess bone age? Just like that.
so on apps, sir, bone expert apps.
Okay. Okay.
In lab
Don't
investigation.
assess just based on the carpal bones.
Yes, sir.
That is an old method. So always look for the radius, ulna, carpals, and the metacarpal phalanges and all. Either you can use Grulich Atlas, Tanner Whitehouse, or bone expert. Okay.
For the lab investigations, baseline normal investigations were normal, including the thyroid profile and vitamin D level. IgTTG level also normal. Total immunoglobulin level is normal. IGF-1 level further somehow it was decreased. 8 AM serum cortisol level was in normal range. Then we went for growth hormone stimulation.
So what is your idea? What is your inference on IGF-1 level?
So in growth hormone deficiency, IGF level used to be less.
Any other condition in which IGF level will be less? In a malnourished child, IGF level will be less. So less than 5 years, especially if the child is malnourished, IGF-1 level can be even low. So that is one fallacy of IGF-1.
Yes, sir.
So continue. Growth hormone, serum cortisol is normal. Thyroid function?
It is normal, sir.
So whether where is the thyroid function?
Yes, sir.
T3, T4, normal.
Normal, sir.
Okay.
Growth hormone stimulation test, tap clonidine.
What will happen in central hypothyroidism?
So in central hypothyroidism, TSH will be low and T3, T4 both will be low, sir.
Okay, that is much more common in panhypopituitary.
Yes, sir.
Continue.
Growth hormone stimulation test was done. Tap clonidine 5 microgram per kg stat dose given. Heart rate, blood pressure measured, were monitored frequently. So this is the result that we got. So the maximum limit, the amount that we at 60 minutes, it is 2.21 nanogram per ml.
Yeah. So what is your inference?
So it is, sir, much lower than the cutoff that is 7. So
it is very, very, very low.
Yes, sir.
Even that. Okay. Suppose the child is already very pubertal age group. What further investigation? How will you do growth hormone stimulation test?
By priming with sex hormones, sir.
Okay, okay. So why you want to do that? To rule out constitutional delay growth and puberty.
Yes, sir. Constitutional delay.
Continue.
In neuroimaging, we have pituitary. So MRI is showing pituitary hyperplasia, in which pituitary height is 1.7 mm. At this age, a normal value at this age is 4.14 mm. And here we can see that the infundibulum is thinned out. The neuroimaging is also in favor of hypopituitarism, sir.
What is called as pituitary stalk interruption syndrome? What are the classical findings? Apart from small pituitary, what are the other things?
Yes, sir.
Pituitary stalk interruption. So panhypopituitarism, what other findings will be there? Structural abnormality. Small pituitary, then absent pituitary stalk, ectopy posterior pituitary. All these things we can expect. Here, this is just pituitary hypoplasia only.
Yes, sir.
Okay. Continue.
So
One
treatment.
question here, Sumit, in pituitary stalk interruption, what will happen to prolactin?
Prolactin will rise, sir.
Very good. Good.
Yes, sir. Treatment growth hormone therapy started with daily nighttime subcutaneous injections at 0.03 mg per kg per day, and further we will keep monitoring the child, the height, pivotal staging, bone age, IGF-1 level, glucose, HbA1c, and
So I think you just monitoring what all things you will monitor. IGF-1.
yes, sir, the height, pivotal staging, bone age, IGF-1 level, glucose, HbA1c, and free.
By HbA1c in all, how many every year you will do? How will you do HbA1c?
Not every year, sir.
Glucose, which glucose? RBS.
RBS, sir.
Every year or is there any guidelines? Serum cortisol you have to measure, because as I told, once even if it is an isolated growth hormone deficiency, gradually sometimes it can develop ACTH deficiency, central hypothyroidism, and even hypogonadotropic hypogonadism later. So every year at least, what we used to do is first after starting growth hormone, after 3 months we'll see serum cortisol and thyroid function test. Then every year we will do serum cortisol and thyroid function test, because child may develop sometimes if there is cortisol level are less, he may sometimes develop, he may produce some crisis. And IGF-1, okay, actually just to titrate it, IGF-1 also you can do. Bone age, okay, very good. Continue.
Ashish, one question here.
Yes, sir.
Suppose child is having a panhypopituitarism, all hormone deficiency. Which hormones you want to start first and next?
So first,
Yes, that is an important question.
First hormone, sir, ACTH, sir.
Yeah.
So if diabetes insipidus is there, still you want to give cortisol first?
Yes, sir.
If diabetes insipidus, vasopressin deficiency is there, what you will do? Before cortisol, you want to start vasopressin, desmopressin? Yes. After
Yes.
that, cortisol. After
Cortisol.
cortisol, replacement. Next, growth
So,
hormone or
Growth
thyroid?
hormone, sir. So last,
No.
the first sex hormone last, sir.
No, sex hormone at a later age.
Or later, it's the last one. That's what I said. Last one.
So what Dr. Amarnath has asked is, first after cortisol, which other hormone you will ask?
Growth hormone.
No, before that.
Thyroid.
Amarnath, is it the answer?
Yeah. After cortisol, thyroid, then growth hormone.
Then growth.
Then
Even-
growth hormone.
Yeah.
So we can start growth hormone late. Actually.
Yes.
Okay, continue.
Adverse effect could be edema, benign intracranial hypertension, glucose intolerance, and worsening of scoliosis. When to stop? So when reaching acceptable height, close to target height, and growth velocity decreasing to less than 2 centimeters per year, or bone age reaching 16 years in boys and 14 years in males. 14 years in girls, and treatment is expensive, and all efforts should be made to ensure that treatment is given correctly and regularly, sir.
Okay,
Yes, sir.
good. Good presentation.
Thank you, sir.
Any discussion? Anybody is asked?
Right.
So
Sir,
what?
Ragupati
Wait,
sir.
suppose
Any comments?
suppose you start growth hormone. Is there any chart in this child? We have started growth hormone.
Yes, sir. We have started growth hormone, sir.
What is the growth velocity? I think you didn't mention about growth velocity even in the beginning. That is very important. Growth velocity.
Sir, actually, child is in our follow-up recently, sir. Only 1 month has passed, sir. So we were unable to comment on growth velocity, sir. So
Yeah. So suppose if you plot growth velocity, what is the importance? In a pure growth hormone velocity, growth hormone deficiency, growth velocity will be at maximum in the first year of giving growth hormone.
Yes.
Then gradually it will come down, but growth velocity will be maximum in the first year.
Yeah, at the starting of treatment.
Yeah. So can you? So what is your idea of giving? You are stopping growth hormone after when the bones are fused and all.
Yes.
Will
Sir.
you continue it?
No, sir.
Adult?
No, sir.
I think growth hormone is having so many other effects also in metabolic functions of the body. So some of the now when a pan-hypopituitarism and all, they will even continue growth hormone in the adult life with a lesser dose.
Okay, sir.
Yeah, Dr. Ashish, 2 questions to you.
Yes, sir.
Do you want to give growth hormone in the morning, afternoon, evening, night, or any time? First question. Second question, any recent advances in growth hormone molecule therapy? Like I don't want to take daily. So
Yeah.
very painful. Anything like that?
At what time you want to give growth hormone?
So morning time, sir.
No,
No.
no.
So growth hormone, sir. Growth hormone administered. We will administer growth hormone in night, sir. During night time, sir.
Why?
You do. Why?
Why?
What is the
Reason
physiology
behind-
behind that?
So,
Maximum secretions.
maximum- yes, sir.
when-
During maximum secretions, growth hormone mainly secretes up at optimum range during sleep.
Very good.
During sleep, sir.
Is it intramuscular or subcutaneous?
Sir, subcutaneous, sir.
So what is Dr. Amarnath's second question? Any newer molecules or advances?
So mainly
Now weekly growth hormone is available.
Yes.
sir.
Or it just came in the market.
Okay, sir.
Good. Any comments from Ragupati sir? Any other? Anjali madam, 1 or 2 minutes. Yeah. Yes.
Okay.
Yes, sir.
So first of all, I would like to thank Ispae, Dr. Amarnath, Dr. Javender for making such type of learning possible for postgraduate students. There are some of my take-home messages. Like this case, although it is of growth hormone deficiency, but by presenting this case, we want to present a case of short stature. How to take history and examination in a short stature, because of course, growth hormone deficiency is very rare condition. Second most important thing is, which we learned through this case, is that growth monitoring is the key. If the child would have been monitored and his growth, especially height and weight, have been plotted regularly on the growth charts, then this condition could have been picked up very early, not at an age of 8 years and 4 months of age. Now, I would, so basically, I want to give a message to residents that even if you are in a busy OPD or in wards, you should make a habit of plotting height and weight routinely on growth charts. Now, most important thing here also is that we should see and document pointers in history and examination whenever we are looking at a case of malnutrition, short stature, etc. So if we will be in a habit to document those things, then we will be able to pick the cause early. And of course, the most important thing is that investigation has to be individualized. Although there is a long list of investigation which has been given, but of course, based on our history and examination, we should individualize the investigations. And of course, it is not possible. It is not there that every short stature needs some treatment. So basically, we should see what is the cause, treat the cause, and then think about the rare causes of shots.
Thank you, madam. Sumit, last one more question. Do you want to do spontaneous growth hormone unstimulated? Many people do. Do you recommend? Yes, Sumit.
Ashish, sir, Ashish.
Ashish, sorry, Ashish. Yeah.
No, sir.
Why you don't want to do unstimulated? Why we do growth hormone stimulation test?
Sir,
Just by getting a basal value,
yes, sir.
can you start treatment?
No, sir.
Why not?
Sir,
Why?
growth hormone basically secreted in pulsatile manner, sir.
Very good.
Excellent preparation by both the candidates and the guides. We are very much thankful. Yes, Raghupati sir.
Raghupati sir.
No, the answer to that question should also include, can we do growth hormone as a basal level in one condition instead of going through all the stimulation tests? It was mentioned excess growth hormone, which is that condition? Growth hormone resistance, which is also known as IGF-1 deficiency. In the case, you can make a spot diagnosis, spotter, and you can recognize Laron's syndrome. And there, you can just do a random growth hormone. And if it is high, no need to do any stimulation test. Okay, that's one point you can remember. But generally, doing a growth hormone random is absolute waste. Okay, you need to do growth hormone stimulation test, and as Ashish said, pulsatile secretion is during deep sleep, not just sleep, deep sleep. Okay, and there will be 5 or 6 peaks during a night, and we don't know when it will come, when it will go, and it doesn't last more than 20 minutes. Okay, and that's why we do a stimulation test. By far, that's not also the best way of demonstrating growth hormone deficiency, but that's what is universally done at present. What you should do is to find out neurosecretory regulation of growth hormone, but that's very cumbersome. You need to take blood every 20 minutes from 9 p.m. to 6 a.m., which is totally impractical. That's all I want to say.
Is a president for Growth Hormone Research Society. Thank you, sir. Now I request Vijay Kumar, Professor, sir, to give a short lecture on growth hormone deficiency. Practical.
Is it visible,
tips.
my slide?
Yes, sir. Go ahead, sir.
I think, what is the time limit? I think you can just
10 minutes.
10 minutes. I think I'll just go through. Whenever you want to stop me, just tell me, Amannath.
Sure, sir.
So growth hormone deficiency is the commonest cause of referral to an endocrinology clinic. And second, the most children are having physiological causes and they don't require any evaluation. Fact 3, many have serious underlying disease for which growth failure may be the only presenting features. So the aim of evaluation is to avoid unnecessary workup in children with physiological cases while not missing any pathological case. So this is step 1 is take height measurement of each child starting from birth and again at regular intervals. That is the most important thing. Like in this child, if you get a length measurement from birth and serial plotting of the length or height at regular intervals, that will be a vital information that will give you an idea in the very early age itself what is going wrong. So these are the usual recommendation of height measurements or length measurement at birth, 6 weeks, 10 weeks, 14 weeks, then 6 months, that is in between 14 weeks, then the child is coming for third immunization, and 9 months for measles immunization, there is a long gap. So at least 6 months, there should be an additional length measurement. Then 15 months, 18 months, once in 6 months till 5 years, and once a year thereafter. If it is done to all children, many of the cases of pathological short stature may be diagnosed very early. Then step 2 is whenever the child is short, what is the definition of short stature? If the height is below third centile, he plotted in a country-specific growth chart, or if it is below 2 standard deviation. And growth velocity below 25th centile in a linear growth velocity chart over 6 to 12 months of observation. So this is the IAP growth chart. So you can see in the first child. So here the height is less than third centile. That is abnormal. And you can see the mid-parental height and the target. So if you plot the target of this child, that will be definitely below the mid-parental height. So this child requires investigation. So another child, you can see his height is between 10th and 25th centile. But you can see the mid-parental height, that is still above that. That is still below the mid-parental range. So this child, even though it looks like the child is normal, but he is very short as per the parents' heights are concerned, and also this child also should be investigated. So mid-parental height is very important. Then the linear growth velocity. This is the Indian growth velocity chart that is prepared by Vaman Kadilkar sir and his team. So you can see if it is between below 25th centile, then you have to look for the growth. So you have to investigate. So you can see that in the next, that is below 25th centile. So this child also should be investigated. Then how to plan the workup? If it is short stature, it can be physiological. So the counseling is the only thing required and no further investigation and management. Then pathological. So evaluation to find out the underlying cause and treat the cause. The familial short stature is the commonest thing that is seen in our clinic. So the height that is short for the population, but normal for the family. So here, monitor the growth velocity. If the growth velocity is less than 25th percentile, then we have to evaluate for alternate cause. And bone age is very much important. So bone age is in tandem with the chronological age that almost give you the diagnosis of familial short stature. Then another thing we have to roll out is constitutional delay of growth at puberty. Here also, serial plotting of the growth chart. Suppose if you get a past documented height record, that will be immensely help you to get a diagnosis. So you can see that child will be born normally, reach the final height normally, but in between he will grow along the third centile in the growing years. Born age is slightly delayed, 1 or 2 years, almost it is in at par with the height age, and the catch up during the pubertal years, and there will be some history of delayed puberty and delayed growth in the family. So that is very important. And much more common in boys compared to girls. So you can see the bone age corresponds to height age in this child. Then pathological causes. So here, the child's height is well below third centile. This child requires investigation. So very short, height below even first centile, investigate. Then another child just below third centile. But you can see that serial plotting of the growth, the height, shows that he is not growing properly. His growth velocity may be less. So even though the height is just below the third centile, if the growth velocity is less, you have to investigate that child. Another thing is, this is between third and 10th centile. It looks as if it is normal, but I have taken the previous height measurements. It was between 10th and 25th centile. Just again previous, that is between 25th and 50th centile. He is gradually moving from the 50th centile to 25th centile and third centile, just above third centile. So there is crossing of the centiles. This child also should be investigated even if the height is just above the third centile. So the serial plotting is very important. So but sometimes the linear crossing of the linear percentiles will be normal in infancy. So suppose the child is having, this is an infant of diabetic mother, birth weight will be 4.5 kg, length 52 centimeter. But 2 years, weight is 11 kg, length is 88 centimeter. But you can see that his height is, his weight and length is much more in the above 97 centile, but it has crossed the centile to 50th centile at 2 years. That is catch up or catch down growth. There is changing of the percentile during the first 2 to 3 years to adjust towards the genetic potential. That is considered as normal. But severe falling of the curve is pathological. Either it may be nutritional or maybe it's due to some chronic illness or something like this. So suppose this, you can see this child. He has also crossed 2 centiles, but from the 50th centile to less than 3rd centile. This is abnormal. This is called as catch-up growth. So, assess the onset of growth faltering. You have to know when the growth faltering has started. So, that is again by collecting the maximum available previous growth record, preferably from the birth. Then plot in a growth chart and analyze. That is the most important thing. And determine when the child started growth faltering, crossing percentile downwards. So when it started, that will give you the diagnosis. So here you can see it is a 3 year, the height is normal. Then you can see that gradually he is falling behind. So he is having now at 9 year, his growth is below, height is below 3rd centile. So there is a definite crossing of the centile, and growth faltering has started at around 3 to 4 years. So what is the when is the onset of growth faltering? This is the 4 time periods. In the case which was discussed now, his child's weight is less actually. The child's at birth. So child's height and weight are subnormal at birth. That is the SGA baby. Growth faltering has started in the fetal life itself. So you have to think of intrauterine infections, or we have to think of some chromosomal anomalies along with, rather than growth hormone deficiency. Now a child is born normal in size. Growth faltering started in infancy. So you have to think of congenital defects that affect the postnatal but not fetal growth. Suppose a child is having a congenital heart disease. His birth weight will be normal. But during the later half of the infancy, because of the congestive cardiac failure, he might have lost his weight and height. Congenital hypothyroidism, height will be normal at birth. Then there is growth faltering. So growth faltering started in the infancy. Think of congenital defect or some malnutrition or something like that. Growth deceleration has started in the childhood. So during infancy and first few years was normal. So it is not a malnourished child. Growth deceleration started in the childhood. Then it may be an acquired disease like systemic illness, tumors, drug-induced, and growth hormone deficiency and other endocrine causes. When the growth faltering started during adolescence, child is having pubertal delay. It may be due to some sex hormone problems. Then setting the target. So mid-parental height is a very important finding. So that is plotted at around 18 years, 6 centimeter above or 6 centimeter below. That is 1 standard deviation above and below. That is the target range. Interpretation can be wrong sometimes if both parents are abnormally short. If both parents are having growth hormone deficiency sometimes, and their child is very short. So even though her projected adult height falls in between these centiles, in between the target range, still we have to investigate. Both parents are abnormally short. Otherwise, if one parent is tall and the other parent is short, that also can happen. So then that mid-parental height calculation may go wrong. So if the couples are like this, the mid-parental height may be having not much of value. See here, I'll share you one photograph of our own cases. Both parents, you can see the grandmother and mother, both are short, and they found out a very short boy for marriage, and both their children, both of them are having growth hormone deficiency. just I compared with this parent with a normal adult male. So both these children are having growth hormone deficiency and on treatment now. Then body proportion, upper segment, lower segment ratio is a very important tool in diagnosing whether it is disproportionate or proportionate. So this is the upper segment, lower segment ratio. That is an Indian standard, again prepared by Vaman Kadlikar sir and all. So if it is upper segment, lower segment ratio is more than 2 standard deviation or outside 3rd and 96th percentile, then it is very significant. Then you have to look for rhizome, whether the child is having, whether it is disproportionate short stature, we have to look whether it is rhizomelic, mesomelic, or acromelic shortening. This is again one case of short stature, but you can see that the upper limbs and lower limbs are shorter, and the child was having disproportionate short stature, and the child was having this achondroplasia. Then step 4 is a careful physical examination that will narrow down the possibilities. So you can see the first girl, all these children are from our case group only. You can see that first child is having short stature, and just by looking at the teeth, you can diagnose the child is having growth hormone deficiency. You can see that this child is having a central maxillary incisor. The next case, the child is having a mid-facial hypoplasia. You can see that typical case of growth hormone deficiency with a prominent forehead and small mid-facial hypoplasia is very evident. Third case, you can see that this child was having hypoglycemia in the newborn period, and you can see that child is having a micropenis. That will give you the diagnosis. Then thyroid enlargement in a child with autoimmune thyroiditis, but this child actually came with short stature. This is a Madelung deformity. This is a short 3rd and 4th tooth that we can diagnose Turner syndrome, pseudo-hypoparathyroidism, Shocks deficient haploinsufficiency. So this is a case of Prader-Willi syndrome. Rickets is a case of disproportionate short stature. You can see a small scar. That child was having a chronic liver disease. Russell-Silver syndrome, you can see the next child. That child is having a difference. You can see the difference in the left and right side. Then Prader-Willi syndrome. And the central lower is Turner syndrome. But this child was missed actually. And this child was diagnosed at the age of 8 years. But you can see that when the child was an infant, you can see that child was having edema of the lower limb. This photo the mother has shared with me. Actually, this child we could have diagnosed Turner syndrome when we gave some importance to that edema in the dorsum of the foot. So whenever the weight is less than the height, always weight age is less than the height age, always look for nutritional causes and chronic illness like malabsorption syndrome or all these things like that. Then this is a case of...
Sir. 2 more minutes.
Okay. Okay. This child is having, you can see that both children are having disproportionate short stature. You can see the rhizomelia. And the central one, that is a congenital hypothyroidism. Always, you shouldn't diagnose congenital hypothyroidism in an older child nowadays because screening should be available. And the screening for thyroid is the birthright of every child. So always all children should be screened. So you can see this girl, typical feature of Turner syndrome. So the lower first child, this is a steroid-induced short stature because child was having nephrotic syndrome and chronic steroid use. This child is having almost all features of Cushingoid syndrome. This child is having a midline cleft lip, always suggestive of hypopituitarism, pseudo-hypoparathyroidism, calcinosis cutis. The next step is investigation. Always bone age is a must. Don't write bone X-ray of wrist, X-ray of hand is very important. Usually, if the bone age is delayed, growth hormone deficiency, hypothyroidism, that will be the first in the list. In CDGP, mild growth bone age delay will be there along with at par with the height age. Very rarely, advanced bone age will be there. If the child is having precocious puberty and the bones has already fused, then the child will come to you with short stature. Then very rarely a CAN mutation and Shock's deficiency, something like that. And if the bone age is at par with the chronological age, always suspect familial short stature. Then these are the investigation. Always do the level 1 investigation. And if the child is having anemia, treat anemia first and growth hormone deficiency after correcting anemia. And if the child is having vitamin D deficiency, hypocalcemia, treat that. The EFSR is high. Child may be having sometimes chronic infections like tuberculosis or some connective tissue disorders. All these investigations are very important. Blood urea, creatinine. Sometimes a chronic kidney disease will come just with a short stature. Thyroid function test is a must. Always do a thyroid function test. In areas where celiac disease is very common, you have to do celiac screen. Karyotype. Whenever a child is having an abnormal features, do a karyotype. And whenever a girl comes to you with short stature, do a karyotype to rule out Turner syndrome, because always you can expect a girl coming to you without any other features, just with short stature. And as told, growth hormone stimulation test, IGF-1, IGF binding protein, and MRI. Thank you. So what is the take-home message is growth monitoring starting from birth onwards. That will give you the early diagnosis of any diseases that will produce short stature and early referral for initiating treatment.
Thank you very much, sir, for giving an overall view revision of short stature. It was very excellent lecture. Now I request Raghupati sir to show light on growth velocity. My professor used to say, Dr. Raghupati, even though pediatrician is unable to record the height, so grandparents used to mark on the wall. Even the school child health program, teachers, everyone should try. Not only, yes, sir.
I don't think I can show you that slide. You should have told me earlier. But it was very nice of a grandparent to take the height on a particular date of the year, every year, for 10 years, for 3 grandchildren. And if a grandparent can do that, why can't a pediatrician do that? And this is why when a pediatric patient comes into the clinic, they not only should have weight, but they should also have height. And no point just recording the height. You should also plot it and see whether it is, whether the child is growing normally, and that monitoring is essential. And I was almost tempted to say when Vijay Kumar was showing a girl child faltering growth from 50th centile dropping to less than 3rd centile. That's the ideal patient to diagnose hypothyroidism. And being a girl child, you know, she's more prone to develop autoimmune thyroiditis. And the age which he showed was also very, very characteristic and were always seen in our clinical practice. You should always remember hypothyroidism. And in such a case, it's a valuable information obtained by growth monitoring, height monitoring at regular intervals. And I must end saying hearty congratulations to Amarnath, Jaivinder, Dr. Kavita Bhatt, Dr. Vijay Kumar, and others involved in this program. I know what a lot of preparation this requires. Hearty congratulations to all of you and my immense gratitude to all of you. Thank you.
Thank you very much, sir. Last but not least, even now, when I see the patient, even for 2-3 months also, I write plus 0.5 kg, sometimes minus 0.5 kg for obesity. So make it a habit. Every time when we record height and weight, please start writing plus and minus. Means that is growth velocity and weight velocity, especially in obesity. Thank you. Now I request our PEP coordinator, Dr. Jaivinder, to come to last session. Around 5 to 10 minutes is the OSCE on growth hormone deficiency and PWS.
Okay.
I request you to restrict to only growth hormone deficiency and Prader-Willi as much as possible. Thank you. Where is Associate Professor? from PJ Chandigarh. He's BP coordinator and also executive council board member from Ispae.
Okay, thank you, Dr. Amar. And this OSCE is based content has been presented by Kavita ma'am, Dr. Vijay Kumar sir, and the beautiful cases by Dr. Ashish and Dr. Sumit. So, beginning with the first question, 12-year-old girl with a height of 132 centimeters, 6 kg, and born age of 12 years. The height age and weight age is 9 years. So mother's height is 148 centimeters, father's height is 160 centimeters. The growth is plotted on this growth chart. And these two red curves are showing the mid-parental, the target range for the child. So the questions are, the question number 1 is name the growth charts which are used for Indian children. So any of the PG can volunteer for the answer.
Yeah, you can type in the
chat box. You can
chat
type
box.
in.
Yeah, I will be reading. Is anyone? Please.
Yeah, second. So all of the questions have been covered in 2 lectures and the case discussion. So you should be able to answer most of them if you have listened it well. So second question is calculation of mid-parental height and target range for the child. And third question
147.5.
Yeah, that's a correct response. And what about the growth charts which are used for Indian children? One of which we have shown in this photograph.
If anybody wants to tell panelist, please can answer by opening their mic. Unmute. Yeah. Next.
Yeah. So
they have written WHO IAP growth chart.
So the answers are that we use Intergrowth 21 charts for preterm neonates. Previously, we used to use the Fenton charts, but now most of the centers are using Intergrowth 21 charts. For 0 to 5 years, we use WHO charts, and for 5 to 18 years, we use IAP charts. So we have common charts with WHO and IAP merged charts are available, which are 0 to 18 years charts, which are commonly available in our clinics. So mid-parental height for the child is 147.5. So correctly for president. So it's average of parents' height is 6.5 for girls and plus 6.5 centimeter for boys. Target range. The target range is basically the plus minus 6 centimeter of mid-parental height, and this is the range in which the child should be growing. So for this child's chronological age is equal to born age, and the child is growing well within the target range. So this is the case of familial short stature. So coming on to the second question, Dr. Vijay Kumar has shown this slide. So what are these charts and at what percentile line we should be worried?
Growth velocity charts, and 20 less than 25th percentile, we should parents pediatrician must be worried if it is less than 25th percentile.
Yeah. Thank you, Ashish, and very good. You have answered it correctly. That growth, these are growth velocity charts, and as sir has shown that Indian charts are now available. We should be using those charts, and the below 25 fifth centile should be investigated. So a 7-year-old girl came for the evaluation of short stature. This X-ray was done as a part of evaluation. So what is this purpose of this X-ray? Anyone?
To calculate bone, to assess for bone age.
Yeah, correctly answered. And name the various method for estimation of bone age.
Greeley-Spiley method, Tanner-Whitehouse method, and artificial intelligence method like Bone Expert.
Yes, correct, Ashish. And enumerate any 3 causes of delayed bone age.
So in most of the cases of short stature, bone age is delayed, like endocrine region or undernutrition or Yes, sir, and genetic
Okay.
chromosomes.
Constitutional, genetic, it will be same, constitutional delay.
Constitutional delay or familial short stature, it would be same. And in
Same.
case of some like Agrican or the Akan ones, so it's not that your bone age would be in every short child.
Yes, sir.
So hypothyroidism, GS deficiency, malnutrition, and any other chronic illness will cause delay in the bone age. And nowadays, Tanner Whitehouse 3 method is used, and it more of rely on this radius ulna and the smaller bones, your this phalanges and this metacarpal bones, rather than this carpal bones. So this is a matching question. So we have 4 options. The bone age is equal to chronological age, which are more than height age. What is the scenario?
Answer.
So first one is familial short stature.
Yes.
Second
yes,
one
correct.
is normal.
Yeah.
Fourth,
Third one.
so
Bone age is equal to height.
Fourth-
Okay.
fourth one is growth hormone deficiency, and third one is constitutional, sir.
Very good.
Yeah, very good. Ashish, you have answered it correctly. So question number 5. Shyam is 80-year-old boy presented with the height of 100 centimeter and weight of 18 kg. 18 kg. Height age is 4 years and bone age is 3 years. And weight age is 6 years. Systemic examination is normal. Celiac serology and thyroid function test are normal. So what further evaluation you will do for the diagnosis?
So thyroid profile, sir.
So thyroid
Growth hormone
normal.
Then growth hormone stimulation test, sir.
Yes, we should be doing IGF-1 and growth hormone stimulation. Indications for growth hormone stimulation test.
Yes, sir.
What are indications for doing growth hormone stimulation test in children? And third question is, in which situation the growth hormone stimulation is not needed for diagnosis of growth hormone?
In familial short stature and constitutional, so growth hormone stimulation test is not required.
Those children are not short, no? They are normal growth variant.
Physiological, sir.
So as we have lack of time, so I will quickly move to the answer. So IGF-1 and GS stimulation test we can do. And the indications for growth hormone stimulation tests are mainly auxiological criteria. So if your height is less than -3 STS, if height is 1.5 STS below the mid-parental height, height STS -2, height is below -2 STS, and height velocity is less than -1 STS. So these are the standard indications for doing growth hormone stimulation test and can be found in any standard book. So, in newborns, for diagnosis of growth hormone deficiency, you don't require growth hormone stimulation test, as Raghupathi sir has described. So in newborns, acromegaly, you don't need growth hormone stimulation test. Or the random GH gives the answer. Approved syndromes like Turner syndrome, Noonan syndrome, Prader-Willi syndrome doesn't require growth hormone stimulation test. In SGA babies, in children who have multiple pituitary hormone deficiency, so in all these scenarios, growth hormone stimulation test is not required. So that Shyam patient was diagnosed and started on growth hormone at 35 microgram per kg per day. 1 month later, the child presented with headache and vomiting. Fundus examination showed papilledema. So what is the etiology of these symptoms? How will you common adverse effect of GS therapy?
So etiology is increased intracranial tensions, increased intracranial pressure.
Yes, Ashish, anybody else apart from Ashish, and anyone else want to answer the second or third question? Assis has learned a lot from his case, and he had read about growth hormone deficiency. Anybody else want to volunteer? So all these things we have discussed. So this, as Assis correctly pointed out, this may be features of benign intracranial hypertension, which commonly present with the symptoms of headache and vomiting. So in this scenario, we stop the growth hormone and we restart with a lower dose. And other common side effect for the growth hormone deficiency are slipped capital femoral epiphysis, pedal edema, dysglycemia, scoliosis. If the child already has some scoliosis, it may increase. And in follow-up, we usually measure the observology, height, weight monitoring. We do IGF-1 level and thyroid function test, and other pituitary hormones would be assessed. And the blood sugar and HbA1c, there are no guidelines for their measurement, but whenever the child is developing any symptoms related to these, then they should be monitored. So question number 7, a 9-year-old boy presented with headache, polyuria, and short stature. The MRI was done for the evaluation and found such lesion as pointed by the red arrow. So what is this lesion? And what will be the endocrine manifestation and the mainstay of management?
So it is
So, yes, it's
craniopharyngioma, sir.
yes, correct. This is craniopharyngioma. Can be associated with multiple
It's a panhepatitis.
deficiency. May have growth hormone deficiency, adrenal insufficiency, diabetes insipidus, and surgical resection is the mainstay of treatment. So other causes of acquired growth hormone deficiency are your LCH, Langerhans cell histiocytosis, may involve the pituitary stalk, and radiation exposure, especially in the brain tumors or any other tumors requiring radiation exposure. So next question is 10-year-old girl presented in OPD for evaluation of short stature. She is short, and the initial investigation, the baseline investigation like blood counts, electrolytes, CRP, are normal. Thyroid function test, blood gas analysis, and celiac spleen is also normal. One ultrasound has been done which showed the bilateral streak gonads, and this is the photograph of the child showing the carrying angle is increased. So these are our questions. What is most likely etiology of short stature in this child?
Turner syndrome, sir.
And which system should be screened and monitored in this child in follow-up?
Sir, cardiovascular system, sir.
Yes.
Bicuspid valve and coarctation of the aorta can be present.
Yes, yes. Hypertension can be there. They have the hearing problem that should be screened, and the cardiovascular system should be screened. Eye should be also be screened, and other endocrinal may also be there. They are more prone for hypothyroidism, type 1 diabetes as well. So which growth charts you will use for this child? So we have Turner available. Those charts should be used for monitoring these children. And name any 3 syndromes which have been approved for GS therapy apart from Turner syndrome. So we have Noonan syndrome, which is approved indication, Prader-Willi syndrome, and Russell-Silver syndrome. So all these are approved indication for growth hormone replacement therapy. So question number 9, a 6-year-old boy was referred for management of short stature. He was born with term SGA. He had a height STS of -3.4 and weight STS of -3.2. So do you require growth hormone stimulation in this case? We have answered this question already in previous questions.
No, sir, we don't require.
And what is the role of GH in SGA? So GH replacement should be given in all SGA children who are failure to catch up in initial 2 years. And as Dr. Amar has described, around 15-20% patients will have failure to catch up that growth. and they should be started on growth hormone replacement if their height STS is below minus 2.25 STS, and it the children grow well when the growth hormone is, so it's an approved indication and it can be started at the age of 4 years. So what is Barker hypothesis in context of SGA or IUGR baby? So this hypothesis is related to metabolic reprogramming, which can happen in these, and they are more prone for metabolic abnormalities in their later life. So they are more prone for developing metabolic syndrome, hypertension, dyslipidemias, diabetes, all these complications, and obesity. Last questions. So this is a image of cella. So parts A, B, C, D, which have been marked.
Yes.
Anyone? So your A is optic chiasma, B is your infundibulum. Sorry. So B is infundibulum, C is your anterior pituitary, and D is your posterior pituitary. So this can, the posterior pituitary bright spot is clearly seen in this image. So these are the parts which you should be seeing in any sagittal cut of the MRI for looking for the cell. Thank you, Dr. Amar. This is all from my side.
Yeah, thank you, Dr. Jayendra. We especially thank Dr. Seema Rai, so, who was supposed to present, and it's modified by Dr. Jayendra. We thank all the participants. Just last 1 minute, the previous question answers complete in 1 minute. So there are 5 questions asked commonly. Indications of growth hormone therapy. What are the causes of dwarfism? Dwarfism is less than -1 standard deviation or less than percentile, like growth hormone deficiency, Turner syndrome, genetic short stature, and the skeletal dysplasia. How to investigate? Already covered by indications of growth hormone therapy, growth hormone in pediatric practice, various functions of growth hormone, and physiology of growth hormone. Commonly asked question. Prader-Willi syndrome questions were asked on the clinical features, genetic imprinting, approaches syndrome of obesity, genetics of Prader-Willi syndrome. So here you have mentioned the ternary complex, that is IGF, PP3, IGF1, and ALS. This will happen in the liver, and also the receptor, growth hormone receptor, that is LAT2-STAT pathway. These are the few questions. Last announcement from the Ispae. So we are having the pediatric postgraduate quiz from 17th to 19th November, but the preliminary rounds is on 18th November. The first prize is 15,000, second prize is 10,000, third prize is 5,000. Must is they should register. So if you see compared to the Ispae members or the other endocrinologists, you are half price. So please register, come physically, and contact Dr. Saujanya. You can take the picture, keep in your WhatsApp groups. Welcome to Ispae 2023 at Bangalore. Thank you very much. Let's meet at Quiz Bangalore. Thank you. Over to Vijay Kumar sir, Raghupathi sir, and other panelists. Any final remarks? Raghupathi sir, you are mute.
I have already said what I wanted to, and I think it's getting late. Thank you, everybody and the team, and we wish you all the very best. Bye.
Yeah.
Thank you,
Thank
Dr.
you, Dr.
Amarnath.
Anjali, and
Thank you, sir.
it was excellent.
It was
you, Vijay
really
Kumar sir.
a great learning for postgraduate.
Thank you.
Thank you. Thank you, sir.
Thank you.
Thank you, sir.
We thank Ankit for giving very back-end support Thank you, RX Events. Bye. See you. Good night.
Thank you.
Wishing you all the best for your final examinations.